Hey everyone, so today we're going to be doing USMLE Step 1 and 2 mock question of the day, number 6. So we're going to start with the patient presentation. We have a 55-year-old female. She has an extensive history of alcohol abuse who presents with 1 day of epigastric pain, also associated with nausea, vomiting. Otherwise, she denies shortness of breath and chest pain. Her vitals on physical examination are unremarkable. On physical examination, you also note some tenderness in the epigastric region. Her rostering and psoas sign are negative. The EKG is unremarkable, and cardiac troponins ×3 are negative. The lab findings demonstrate a markedly elevated lipase, which is more than 4 times the upper limit of normal. So, what is the next step of treatment? And in order to answer that question, you should also be thinking about what the diagnosis for this patient is. So, the options are surgery, conservative management with bowel rest and IV fluids, conduct a CT, or prescribe antibiotics. Take a second to pause the question right now if you need additional time. The correct answer for this question is the next step in management should be conservative management with bowel rest and IV fluids. As I'll explain in more detail in a second, this patient's diagnosis is acute pancreatitis, given the fact that this patient does have elevated lipase and epigastric pain, and the management for acute pancreatitis is just conservative. You don't have to do surgery, you don't have to give antibiotics, and in this case, you don't even have to do CT, just given the fact that this patient does have the clinical markers for acute pancreatitis and also has elevated lipase. And so, briefly, I'm just going to go through the question stem one more time, pointing out what are the important things that you should know as you're reading this question. So once again, we have a 55-year-old female. She has an extensive history of alcohol abuse and presents with 1 day of epigastric pain associated with nausea, vomiting. Whenever you're reading a step 2 or step 1 question, they tell you abdominal pain, the first thing you should be thinking about is the location of the abdominal pain. In our situation, the examiners tell us that it's epigastric pain. And so whenever there's epigastric pain, there are 4 major regions, 4 major organ systems you should be thinking about. You should be thinking about the heart, the lungs, the pancreas, and the GI tract. Those are kind of located in that region, and pathology in any of those 4 different organ systems can be causing the pain. And so from a cardiac perspective, it could be an MI. From a pulmonary perspective, it could be something like a pulmonary embolism. From a pancreas perspective, it could be acute pancreatitis that we see in our patient right now. And then from a GI perspective, it could be things such as gastritis or ulcer. Moving on to the next line, patient denies shortness of breath and chest pain. The major point of this line is just to let you know that the fact that the patient doesn't have shortness of breath tells you it's less likely to be something like pulmonary embolism, in which you very frequently see tachypnea. And the fact that the patient doesn't have chest pain also makes something like ACS less likely. Moving on physical examination, there's tenderness in the epigastric region, which isn't surprising. The rostering and psoas sign are negative. So this is just meant to be a herring. The rosterings and psoas sign are just markers of acute appendicitis. And in this case, we're not suspecting appendicitis to begin with. Generally, that pain is in the right lower quadrant. Moving on, EKG is unremarkable and cardiac troponins are negative ×3. This line in particular tells us that ACS is very unlikely. In case the patient did have STEMI, in that case, you would expect some sort of abnormalities in the EKG. And if a patient did have NSTEMI, you would expect some sort of abnormalities in the cardiac troponins. So once again, ACS is very unlikely in this patient. Lastly, lab findings demonstrate a markedly elevated lipase, more than 4 times the upper limit of normal. Now, given the fact that this patient has epigastric pain in the setting of this elevated lipase, tells us almost without a doubt that this is acute pancreatitis. And what you want to remember is, if their amylase or lipase is more than 3 times the upper limit of normal, that is usually the cutoff for acute pancreatitis. So it's really important to remember that cutoff in case they do test it. And what is the next step in treatment? We've already gone over this for acute pancreatitis. Just manage it conservatively with bowel rest and IV fluids. The next few slides, I'm just going to go through the clinical presentation, diagnosis, and management of acute pancreatitis. So with regards to clinical presentation, generally patients report abdominal pain, which is epigastric, and it may also radiate to the back. The vast majority of patients also report nausea and vomiting. Given the fact that the pain associated with acute pancreatitis is fairly nonspecific and a lot of other things can be causing it, diagnosis may be more challenging, and that's why patients who are suspected of having acute pancreatitis, typically one of the first things you'll do is order amylase and lipase. It's also important to note that most cases of acute pancreatitis are also secondary to alcohol abuse and gallstones. And if you'll remember from our question stem earlier, our patient did have a history of alcohol abuse, so it's likely that her case of acute pancreatitis was due to that. Moving on to the diagnosis of acute pancreatitis. So in order to be able to diagnose it, you just need two of the three things that I listed here below. One is the patient needs to have upper abdominal pain, you need serum amylase or lipase 3 times upper limit of normal, or you need imaging consistent with acute pancreatitis. Like I mentioned, if you have two of these things, you don't have to do a third thing. So if we know the patient has abdominal pain and that their serum amylase and lipase are 3 times upper limit of normal, or more than 3 times upper limit of normal, we can assume it's acute pancreatitis and we don't have to do imaging. One important caveat to this is, while imaging isn't required for a diagnosis, it is recommended if patients fail to improve after their first 2 to 3 days. And the point of that is you just want to assess for any complications like the formation of pseudocysts or any other potential things where you might have to do some additional management. Lastly, the management of acute pancreatitis. The main things you want to focus on are aggressive fluid resuscitation, make patients NPO and advanced diet as tolerated, start IV opioids in case the patients do have pain. And this is one of the things that if you've ever taken care of a patient with acute pancreatitis, they'll have very severe epigastric pain. So pain control is incredibly important. And the good part is most patients, the majority of patients with mild pancreatitis don't require any additional treatments apart from things that we mentioned, and most patients in general recover in 3 to 7 days. So that's going to be it for this presentation. I hope it's helpful.